parents of 2-year-old boy complaining about the child's moving eye from side to side. The moving eye had been present since he was 5 months old, but not so obvious, and the parents just ignored it. Later, the parents realized the movement became obvious as their son grew up. It's reported, patient's mother had a normal prenatal history and the baby was full term and has normal birth weight. Therefore, the parents bring him for the first time eye examination. Overall, the boy has unremarkable of ocular and medical history. There is no pathology shown on the MRI scan too. Based on this case, there are a lot more information that can be figured out from the parents. First, we can ask the parents does the moving eyes happens to move all the time or intermittent. Next, does the boy has associated symptoms such as blurry visions or oscillopsia? We can ask also the parents about the presence of abnormal head posture of the boy. The information of ocular history, we can ask the parents that does the boy ever experience trauma or any surgery on the eye. For medical history, we can ask the parents that does the boy having any systemic disease or taking any medication, as some medications will induce the condition of the vision. Last but not least, we can also ask the parents that does any family members from both sides experience the same condition as the boy, or does anybody in the family has genetic disorders such as albinism or retinitis pigmentosa, as these conditions will cause the abnormal movement of the eye.
What happened to my son? Why his eyes move from side to side?
The condition eye move from side to side is referring to nystagmus. Nystagmus can be defined as involuntary eye movement. It is normally consists of slow eye phase and quick eye phase, which bring the eye back to the initial position. The prevalence lies around 0.1%. The most common found nystagmus are congenital nystagmus, acquired nystagmus, and induced nystagmus. Congenital nystagmus present at birth or soon after. Acquired nystagmus occurs secondary to some inducing factor such as neurological disease or drug toxicity, while induced nystagmus can be induced physiologically, which is optokinetic nystagmus and vestibular nystagmus. Based on this case, the parents noticed that their children had condition eye move from side to side since he was 6 months old, and therefore that children might have congenital type of nystagmus. There are 3 common nystagmus occur in infancy, which are infantile nystagmus, latent or manifest latent nystagmus, and spasmus nutent. As infantile, latent, and spasmus nutent all occur during childhood, it is important for us to know the characteristic between them before we diagnose the nystagmus. Clinically, nystagmus is characterized by amplitude, frequency, direction of gaze, which it presents, and the waveform. Infantile nystagmus is usually primarily horizontal in direction, although vertical or torsional movement can also be exhibited. It increases in periphery and have pendular waveform, while latent nystagmus is a conjugate jerk horizontal nystagmus, which emerge only with monocular occlusion and decrease in gaze toward covered eye. Spasmus nutent is a rare form of nystagmus with jerky fine nystagmus, which is horizontal, vertical, rotary, or combination. It also involving the head bobbing and sometimes holding the neck in abnormal position. The associated disorder or causes of congenital nystagmus are congenital cataract, retinal dystrophy, cone dystrophy, high refractive error, albinism, aniridia, Peters anomaly, congenital cornea opacity, macular hypoplasia, optic nerve hypoplasia, and retinitis pigmentosa.
Visual acuity test is to assess the extent to which vision may be affected. For INS, it is either 6/18 or better, or reduced VA due to visual deprivation and myopia. For NNN, often associated with amblyopia, for SNS, VA 6/15 or better. Refraction is to determine the appropriate refractive status. For INS, high prevalence of astigmatism. For MNN and SNS, amblyopia may present. Cover test is to identify the eye's deviation, and H-foot test is done to observe the eye's alignment. For INS, some is non-strabismic, while some may have associated strabismus. For MLN, mostly will have strabismus. For SNS, high incidence of strabismus. Near-point convergence test is to observe the behavior of the nystagmus on convergence. For INS, the intensity of nystagmus reduces upon convergence.
ERG, which is a test to detect function of rods and cones, can be done to confirm the diagnosis. Normal findings show in infantile nystagmus, manifest latent nystagmus, and squamous nutans. BIO can be used to detect any anomalies in posterior eye. In infantile nystagmus, normal or anomalies found if there is associated factor like albinism, while normal fundus show in manifest latent nystagmus and squamous nutans. Slit lamp examination also useful in detect anomalies in anterior eye. In infantile and manifest latent nystagmus, normal or anomalies found if associated with ocular disease such as albinism or congenital cataract, while squamous nutans show normal finding. OKN response, which is a combination of smooth pursuit and rapid saccade eye movement, can be done. Infantile nystagmus will show reverse response, which fast wave move towards the direction of the stimulus, while manifest latent nystagmus show asymmetry response. Presence of head posture can be determined. Normally, abnormal head posture present in all three types of nystagmus. Intensity in different gaze can be also determined. In infantile nystagmus, intensity tempered with convergence and null zone. In manifest latent nystagmus, intensity maxima in abduction and minima in adduction of the fixing eye, while squamous nutans show varies intensity and increase if the head is immobilized.
So, madam, these are your son's findings. Uncorrected PA was indeterminable. Both eyes had central and steady fixation of a large target. Pupils were round, equal and reactive to light, with no evidence of an afferent pupillary defect. Eyes appeared aligned with cover test and H-foot test. EOM test was full. The patient had a constant horizontal pendular nystagmus of moderate frequency. The nystagmus dampened moderately with convergence and increased moderately on peripheral gaze. There was a positive latent component. Non-cycloplegic refraction RE minus 625 minus 075 times 70, LE minus 5 minus 1 times 20. For cycloplegic refraction, RE minus 6 minus 1 times 70, LE minus 4.75 minus 1.5 times 20. Anterior segment showed no ocular pathology and no transillumination defects of the iris. The ERG test was normal.
Infantile nystagmus. What are the symptoms? First symptom that patient with infantile nystagmus experience is photophobia, which is sensitive to light. Next is the eyes move side to side. And the third symptom is diplopia, which is double image. And the last one is the eyes cannot fix on object. So, what are the signs of infantile nystagmus? Patient will have reduced in acuity, abnormal head posture, reduced in depth perception, reduced in contrast sensitivity, color vision problem, which is achromatopsia. Next is conjugate and horizontal nystagmus, dampened with convergence. Nystagmus decrease during non-visual tasks, and the last one is abolished in sleep. So, what are the associated disorder of infantile nystagmus? Next, strabismus, optic nerve hypoplasia, albinism, congenital corneal opacity, aniridia, congenital cataract, and the last one is retinal dystrophy.
By looking at the examination findings, we can conclude that the final diagnosis is infantile nystagmus syndrome. What is infantile nystagmus syndrome? It is a rhythmic oscillation of the eyes that has an onset during the first 3 months of life. The oscillation present in primary position has a symmetrical jerk and pendular waveform. The oscillation remains horizontal in all gaze positions if it is idiopathic, and if it is associated with sensory loss, a vertical or rotary component may present. The intensity will increase with visual attention and also anxiety, and it is damped on convergence and with lid closure, and it is abolished during sleep. What are the risk factors? There are several factors that may increase your chance of nystagmus. First one is family history of nystagmus. The second is conditions that affect the brain such as tumor. Lack of pigmentation resulted in reduced vision such as albinism. Eye disorders such as optic nerve degenerations or severe astigmatism or severe nearsightedness. Inner ear problems such as infection or irritations. Thiamine or vitamin B12 deficiency.
What is the optometric management for this condition? Let's discuss it together. Firstly, we should prescribe refractive corrections such as spectacle or contact lens. Spectacles are easier to care for children. However, spectacles are not suitable for patients with abnormal head posture due to eccentric nerve zone, as it may require them to use the eccentric point of the lens. This will induce prismatic and peripheral lens aberration effect, which leads to blurred vision and astigmatism. Patients are required to wear the spectacle for full time, and after 6 months of period, patient needs to come to the clinic for us to review the visual acuity and nystagmus. Contact lens can also be prescribed for refractive correction, as it maintains the optical center with patient's vision axis. However, contact lens has disadvantages such as increased risk for ocular infection and highly depends on parents' motivation.
Next, management that can be given to patients whom the nystagmus is dampened on convergence are without prism or over minus lens. Without prism are prescribed to stimulate convergence, and over minus lens are prescribed to induce accommodative convergence. And this two approachment is to improve the visual acuity by dampening the nystagmus of convergence.
The next one is York prism. York prism are used to correct the abnormal head posture. York prism are placed with base in direction of turned face and apex towards the gaze. York prism is suitable for patients with small head turn because prism with 10 prism diopter and above will cause the spectacle to be heavy and cosmetically unacceptable even with high index prism.
Next is vision therapy. Vision therapy is done when the patient reach age 5 to 7 years old or at any age provided patient can give sufficient cooperation. Vision therapy can be divided into two: vision enhancement therapy and feedback therapy for ocular control. Vision enhancement therapy is a therapy to stimulate binocularity, and feedback therapy for ocular control is a therapy to enhance the control of the eye.
Lastly, patient can also be referred to ophthalmologist for surgical or pharmaceutical intervention if required.